meaningful issues. And so I'm going to be talking about specifically how we tried to use some causative qualitative methods to really delineate factors that are driving the adoption and use of evidence-based practices in systems that use independent contracting. And I think this is a really tricky issue and one that I'm excited to talk about. Before I get started, I just want to acknowledge the awesome team that I'm a part of at Emory University and our community partners. And so the work I'm presenting on today is conducted in partnership with Georgia's Department of Public Health, which oversees their Part C early intervention system. So that the slide kind of talks through some of those team members as well as our awesome research team. A roadmap for today, I'm going to start off just giving a snapshot of what autism evidence-based practices are, especially in our toddlers, and then talking about where the heck we implement those things, right? And I'll be talking specifically about public early intervention systems and what they are, and some of the implementation challenges that we bump into in our early intervention systems. And then we'll be diving into a project that our team really kind of took on to understand some of the factors, right, that are driving the uptake and use of practices in these systems. And again, really with the focus on these independent contracting models and some of the implications of the work that we've done. All right, so autism. So I think it's obviously important to just set the stage that we know that 1 in 36 school-age children have autism, and we hear this all the time, right? Early access to high-quality services is super important for lots of reasons. It can help boost kids' social communication skills and really give them the tools to advocate and to have kind of really kind of improved quality of life. And so we're thinking about how do we, help kids access these really, really good care at an early age, and that's a tricky thing to do. It is not easy for lots of different reasons, but we're thinking about, again, our toddlers and kids under the age of 3. So when I say autism evidence-based practices, there's a lot of different interventions and services that are available. But for toddlers, right, so these are our kids who are 36 months and younger, we often are talking about interventions that are parent-mediated or caregiver-mediated. And so what that means is that a provider is working with a parent and really supporting and coaching them to use strategies that we know impact a kiddo's development. And so this is a more complicated intervention because it uses a family coaching model, but it's associated with all sorts of really important outcomes. So we know, right, that parents who are able to participate in these interventions learn and use strategies in a really meaningful way, and things like bath time and mealtime and dressing routines, and that they report feeling more empowered and efficacious by doing so. We also see that parents' use of these strategies has a downward impact on their kiddos' development, right? So we see that kids have improved communication skills and reduced challenging behaviors. I just want to talk a little bit about the specific strategies that parents are taught as part of these intervention programs, because I think that is really important. So the types of parent coaching that we're talking about are kind of a class of evidence-based practices that are called, have a very long acronym. They're called naturalistic developmental behavioral interventions. And so as part of these interventions, parents are taught developmental strategies. So these are strategies where caregivers are, right, following their child's interests and building upon their interests and really responding to their kiddos' communication in meaningful ways. And so these are our developmental strategies. And then we're also giving caregivers tools to think about, okay, in these situations that your kids love, how do you model and show new skills and reinforce kids learning new ways to communicate? And so again, our focus here is on this very specific kind of parent coaching model. There are all sorts of manualized programs that fit into this category of interventions that I'm talking about, and this slide just shows some of them. And I just wanted to kind of say that our team has been focused on one specific version of this intervention called Project Impact, and that stands for Improving Parents as Communication Teachers. So the question then becomes, right, we have these interventions that we really feel like are best practice for toddlers, and how the heck do we get them into systems, right? And really think about access to services in a high quality way. And so a lot of the work that has been done in this area has focused on Part C, early intervention systems. And I'm just going to lay a foundation for what these systems are and why we care about them, and what sorts of things they do. So Part C systems are federally mandated to provide services to kids birth to 3 with developmental delays under Part C of the IDEA. And the way this works is that basically Part C provides funds to each state to implement a system that is coordinated and comprehensive and multidisciplinary, that then delivers kind of these services to kids under the age of 3 with developmental delays. And so the funds are allowed, you can use them for different purposes, but again, we're thinking about kind of coordinated early intervention. There's some real benefits of the system when we think about access to care. So Part C systems in the US serve about 400,000 kids a year, and again, in this birth to 3 window. And we know that about 10%, potentially more, but our research shows that about 10% of kids who are served in EI systems screen as being more likely to be autistic. And so this, again, we have a large group of high likelihood kids, and about half of all autistic kids were served in Part C systems under the age of 3, right? So it really is this nice service entry point at a young age. And the beautiful thing about the system is that you don't need to have an autism diagnosis to access services. And that's super important, because many kids, right, are not accessing that diagnosis until after the age of 3. And so this is a window by which we can provide services to a large group of kids without necessarily needing that diagnosis. But it's super complicated. It's not a straightforward issue to think about how we increase access to autism evidence-based practices in this system. And a lot of folks, I would say maybe not a lot, but many people have thought about this issue and have been studying it, especially over, I would say, the last 5 to 10 years. So some of the challenges that pop up are ones that are not unique to Part C and public early intervention systems, right? The first being that providers report inconsistent knowledge and use of evidence-based practices for autism. We know that actually provider participation in training initiatives focused on autism evidence-based practices is pretty low. In fact, quite low. So not only do they not know about these things, when they're made available, the uptake is not all that great. And it's not always that easy to learn and deliver these practices with good fidelity, right? So even when providers do participate, we see really inconsistent fidelity, and we see some providers learning these interventions, but many, right, having kind of inconsistent trajectories over the course of training. And then I think just layered on top of all that is, like many public systems, early intervention systems are underfunded, right? They have significant workforce turnover. And I think really interestingly is that about half of states use independent contracting models within their early intervention system. And so what that means, right, is that the state is either contracting with agencies or contracting, in the case of Georgia, with individual providers to deliver services. In the case of Georgia, right, where there is independent contracting with individual providers, there are not really organizations or structures to kind of group providers and affect change. So it can be quite tricky. But our job, right, being new to Georgia, moved there 3.5 years ago and was new to that Part C system, although had been in other Part C systems. The goal is to unpack this complexity, right? I think, we see all these implementation challenges, and I think the thought is, well, where the heck do you start? How do you figure out what to do? And we wanted to really try and distill down what some of the main issues were in the system for when it comes to autism evidence-based practices. So we were particularly interested in understanding determinants at the provider level, the organization level, and the system level together, right? There had been some previous work done before we started this landscape project and needs assessment that had been focused on specific components, either just provider attitudes or just organization level factors. And we wanted to try and understand these things. And then the other thing we were thinking, obviously, is, okay, well, if we can figure these things out, right, and we have a good sense of what the specific determinants are, maybe we can start to think and partner with our state around implementation strategies. We were mindful, right, that in complicated systems, it is important to try and understand mechanisms and causal relationships, right? Not just to have a list of all the things that matter, but to try and understand why they matter. And so our main goal here was to try and figure out that why component, right? Not just the determinants themselves. So we wanted to know, right, how is it that these determinants act and why they have the impact they do? And this we were hoping might help us make some hypotheses about implementation mechanisms, again, to give us that level of specificity. And so the question that we asked was, well, what is the best way to do this, right? And what is the best way to do this in a, right, this is a relatively new partnership, right? This is, and we don't have a lot of funding to do this. So what's a really pragmatic or kind of, easy way to at least start to get at some of these things? All right, so I'm going to talk a little bit about the project that we embarked on with our Part C system. And so what we wanted to know, right, again, really thinking about adoption as kind of one of the main issues is, what does early intervention providers' participation currently look like in autism evidence-based practice training initiatives? And what factors are perceived to causally drive providers' participation in these training efforts? And again, really going a step further, and what are kind of the processes or mechanisms by which these factors operate? So the system that we are working in, right, is Georgia's Part C early intervention system, which is called Babies Can't Wait. And it's housed in Georgia's Department of Public Health. And it serves about 20,000 children every year, about 3,000 of whom screen as having a high likelihood of having autism. And the system includes about 750 providers. And these providers represent different disciplinary backgrounds, ranging from speech language pathology to occupational therapy, physical therapy, and what are called special instructors, which is kind of like a catch-all developmental therapist. And I think that the thing to know that is important, that I've already alluded to, is that our state uses an independent contracting model by which the vast majority of all providers are single providers who contract independently with the state, right? These are not providers housed within an agency, right? They are grouped into health districts. There are 18 health districts in Georgia, but those groupings are relatively loose. And this has implications, right, for the uptake and use of practices, because independent contractors often act relatively autonomously, right? They are not employed by the state, and they have a lot of flexibility in when and how they practice. And so this certainly impacts the quality of care. So we first started off with a quantitative survey. We were just interested in understanding at a very basic level, what were providers, again, how were they participating in training, and what types of practices were they reportedly using? And we're trying to distill, were there certain factors that at least were, associated with some of those things? And so we were able to survey about 100 providers in the system. And again, most of these were in the birth to 3 space, so most are female. And again, 87% of those who we surveyed were reported being independent contractors, right? Again, contracting directly with the state. And again, representing lots of different disciplinary backgrounds, but predominantly like these catch-all developmental therapists and speech language pathologists is kind of our majority grouping here. We also collected some information on provider attitudes, their organizational support, so how much support they've received, which in hindsight we realized was probably not the best thing to collect in a system where there really isn't a whole lot of organization, but we wanted to just give it a shot. And then we looked also at things like implementation, climate, and reported use of autism evidence-based practices. So in that survey, we learned that providers reported using some evidence-based practices, but is extremely variable. And this is also, I think, what's hard, I think, is that this is also a provider report survey where, I don't know that we know for sure exactly what people are doing. And then providers' attitudes predicted the extent to which they reported using different strategies. All other things did not, right? So organizational support did not, implementation climate did not. And I think, in hindsight, again, maybe this wasn't surprising given what we know about Georgia, but I think it left us really feeling like, well, like what does matter then? Obviously provider attitudes are very important, but at the system level, we think there's some other things going on here. And like anecdotally, we see these things play out, but how can we really capture those things? And so we really felt like the survey gave us an incomplete picture of what was happening. So we embarked on a project that was, and this was a new method for me, but we were thinking about, okay, well, let's use some qualitative methods here to try and hone in on what's happening. And so we used qualitative, we did qualitative interviews and focus groups, which I'll talk about here in a little bit. And we used causation coding as a way to try and distill down what was happening. I'm going to talk a little bit about what that is. So causation coding is an adaptation of attributional coding. And so an attribution is just a belief that someone has about events and their causes, really simplistically. And so I appreciated this quote, and I thought it really nicely summarized what attribution theory is, so I put on the slide. But right, it concerns the everyday causal explanations that people produce when they encounter novel, important, or unusual, or potentially threatening behavior and events. And according to attributional theorists, people are motivated to identify causes, right, such events, because by doing so, they render the environment more predictable. So we're kind of operating under this assumption that this is a complicated system and people are trying to grapple with what the heck is going on. And let's try and leverage that to understand their perceptions of causality. So causation coding, which there's a really nice chapter on it in Johnny Saldana's Qualitative Methods Handbook, right? But again, it's extracting attributions of causal beliefs from participant data. And so it uses a coding process that looks for antecedent conditions, mediating conditions, and specific outcomes. And it can serve lots of different purposes. We did try and use it not just to, document out some of these preliminary causal relationships, but also to help us potentially diagram how these factors are operating together in our system. So we did interviews and focus groups with 36 early intervention providers and 9 state-level administrators. And this slide just represents the demographics of those providers. Again, most of these were independent contractors, and then our administrators were folks who are either at the state level in various training roles, and there were a couple of also health district coordinators. So folks who are some of them are counties, but most of them are kind of large districts encompassing multiple counties. We struggled with what framework to use to guide our project, and we went back and forth for a long time on this, I think, and we decided, we're like, I think we're really interested in the system here, in the infrastructure in the system, and how this might be impacting service uptake and use. And so we actually decided to use infrastructure framework that we had came across and thought that was really nice, that spells out some of the main kind of factors that impact the use of evidence-based practices in different service systems. And so this framework really, again, centers on these factors impacting service uptake with a focus on the system level. And so what we really appreciated about the framework is it breaks down some specific things, right? You can see on this slide, it focuses on the workforce, right? And that includes things like independent contracting, which we were very interested in understanding. It thinks about things like leadership support and the types of leadership support that's available to use evidence-based practices. It thinks about things like community engagement, public awareness and support of evidence-based practices, funding capacity, and the capacity of systems, right? Super important to monitor and evaluate kind of program outcomes. And so again, we focused on within our interviews, we focused on factors broadly impacting service uptake, but then we focused in on independent contracting, workforce issues, leadership support for evidence-based practice use, funding capacity, and then kind of an emphasis on, what might be the strategies in some of these domains to impact use. So the way that this coding process unfolded is that we developed a code book in a very conventional way. But what happened was we then layered kind of causal coding on top of that. And so we developed our code book, we applied the code book, and then our coding was reviewed by a third person. We facilitated consensus coding. We continued this process across 11 interviews or focus groups until saturation was reached. We felt like saturation was reached relatively quickly. We heard very consistently kind of what some of these issues were, and it was actually remarkably consistent, and that made coding a lot easier. After we had developed the code book, so as we were coding, we had a causal code that we were using. And so anytime, and I'm going to talk a little bit about how we use that code, anytime a causal inference was made, we coded that as kind of a causal inference. And then once we were done coding, we pulled all causal statements into a separate data set. And so examples of causal inference included things like sentences that use the word because. That's a really obvious example. I don't attend training because I don't get paid to do it, right? If-then statements. If there was more peer-to-peer connection, I would feel more supported to use evidence-based practices. Or statements like so or that to make directional linkages. The paperwork is so high that I don't have time to attend training. So we pulled these apart and again, then went into all of our causal statements and tried to break them down a little bit and to categorize them based off of common causal inferences that are made. And again, this is provider reported causal inferences, but I think what we heard over and over again, I think was really important. When possible, we tried to break these into 3 parts, again, where we have kind of an antecedent, we have the process, and we have the outcome. That was not always possible. People don't always tell you the nuances of how and why things happen. So sometimes there was only 2 parts. But we then extracted this data and used it in a preliminary way with our state partners to start to diagram out what some of these factors are. We then member checked with, obviously, our participants. We actually held, I'm going to talk about this in a little bit, we held a series of roundtables where we presented back our data and worked with our state to take the data and to really start to do some diagramming. All right. Oh no, I don't know why my slide, there we go. Okay, so some of what we learned, I just wanted to kind of give a general description of training participation. I think the thing to know in our system is that there's a lot of inconsistency, which maybe is not surprising, but providers go through a process in any system where they're onboarded, there's formal training opportunities, right? And then there's all this informal kind of mentorship or supervision that might happen. And the yellow and red, yellow represents things that are happening inconsistently. Red represents things that were not happening at all, and green are relatively consistent things that were happening. And so, right, all providers enter the system when you're contracted, and you still have to do some online modules to enter the system, but there's varied, ability to then kind of shadow or get mentorship before you start seeing families. CEU opportunities, folks are required to get a certain number of CEUs per year, but there's no mandated specific training that you have to get, right? There's just a menu, and actually if you go on to the website of all the options that are available, there's hundreds of options, right? It's quite overwhelming actually to figure out what might be important and in terms of what's available for formal trainings. There are some monthly full district health district meetings, right? Again, these are large teams that consist of upwards to 50 to 100 providers that are focused really on just like coordination, right? So kid comes into the system, who's going to see them? Some very operational focused meetings, and there is no formal peer-to-peer kind of support in the system, and we heard this loud and clear. So I think this is just a nice way to kind of document, right, that there's lots of ways that people can encounter and have the option to learn and use evidence-based practices, and this is just some of that. So what were the causal factors that we learned about in our interviews? There were, I think, 5 main components or main factors that we learned about. And I'm going to break down for each of these some examples of just causal statements to give you a sense of how we went about doing that. The first, not surprising, is independent contracting. So this is at the system level. Operational demands in the system, turnover and recruitment issues, inconsistent priorities, and lack of peer-to-peer support were kind of the main themes that we heard. So what does that look like? So this is a statement that we heard from a provider, and I'm going to show you kind of how we broke it down. And this, for anyone who's done work with independent contracting, this statement will resonate. So they say, but it's the unpaid time, because face-to-face is one thing, but then it's all the non-billable paperwork outside of that. And most trainings are not reimbursed. And so other providers start saying, I'm not making enough money to do this, right? Or to get training, or to keep this job, and they go out and do a different job. And so, right, we then were like, oh, this was flagged, right? And so we went in and broke it down in a way like this, right? Independent contracting, unpaid time, right? There may even be some factors kind of in between unpaid time and turnover, but that unpaid time leads to things like burnout, feeling undervalued, and people are leaving the system. Another person said, so even though I have that many special instructors or providers, a lot of them are part-time. So they only see children between, let's say, 4 and 6 o'clock during the week. That is just part of contracting that makes it hard to require anything from them. So they won't do those things. And I know that that's a vague, but the context there again is that, right, part of the contracting structure is that there's not the ability to require providers, at least given how the contracts are structured right now. And so they're not going to do the trainings or any kind of training. And so again, our causal little diagram here, we have independent contracting. And I, have had some interesting conversations today. The way that the contracts are structured, right, they're structured in a way so that currently providers can't be required to do certain things. And so they don't do those things. But we think that can change. Just again, I want to hit on independent contracting again. And so for some of the private providers, it's not worth the money that they were paid for versus them being able to see kids during that hour or 2 at training. So I don't think it was financially a benefit, and they don't attend trainings because they're losing money and they're losing time being there. So just again, really hitting home how the structure of independent contracting really disincentivize folks training attendance for evidence-based practices. I do want to talk a little bit about operational demands and some other factors. I think this is not unique to the early intervention systems at all. That's prevalent across public systems. But this, again, this administrator talks about, because of the contracting process, there's lots of documentation required that makes bringing people on a very cumbersome process. That's probably why the quality assurance doesn't happen, because we're just trying to get the basics done or down. So again, we have high operational requirements and demands. Some of them are federal reporting priorities. Really means that the emphasis of kind of a lot of the training that's happening is on these operational requirements, and it makes it very hard to dedicate time to quality assurance and training in evidence-based practices. And then I just want to talk about turnover and our kind of peer-to-peer issues in the system. So as you can imagine, right, with high operational demands and with the use of independent contracting, there's a lot of turnover in our systems, right? And so this person says, I've been here for 4 years, and I think there's been 3 directors at the state office. So the turnover is huge. And honestly, it's almost a babies can't wait as a moving target. Just when you think I've got this, or that we're prioritizing this thing, no, we have a new leader. And so now we're kind of switching priorities. And I think this is super important. And I will say in the 3.5 years that I have seen that turnover at the state office, right? And it does make it very tricky, right? So we have turnover, we have changing leadership, and by way of changing leadership, we're really changing priorities and changing messaging around what is a priority to the system. We heard a lot about incentivization. I'm sure this is not surprising, and really the need for incentivization and leadership support. And so this person says, like, we have funding issues and limited funding dedicated to training. So some districts don't put on trainings. It takes a lot of manpower. And if you're short-staffed or don't have kind of a coordinating council that's active, you just can't do it. And so again, just hitting on the fact that we have these funding shortages in the system, and that certainly, right, is going to impact the quality of care in the system. I want to end by talking about provider networks, because I think this was something that I found to be particularly interesting, especially when we think about some of these systems that have really isolated providers. And so a lot of the contractors who participated in this project talked about peer-to-peer support. And I thought this was really interesting. So they say, you know, the disadvantage of contracting is we don't always know who to call for support. And we have to search if we want it. And that's hard. You feel like you're bothering someone and you're interrupting them in their day. And so this person, we don't have a middle piece here too, but like they're talking about, man, we are isolated, right? And we have very limited social support and methods by which to kind of obtain and learn more about high quality care in the system. And so after we, like, as you can imagine, this is a lot of data that is focused on really, I think, complicated issues. And we, as a team, we're trying to figure out, well, how the heck do we process this? How do we synthesize it in a way that is not so overwhelming, right? And that is, and so we used kind of the subsequent months after data collection to actually figure that out. Or try to figure it out. So we presented our data back to roundtables in our Part C system. And so we presented it back to some of the same providers and also different providers. So 50 administrators and 10 providers over a series of 5 roundtables. And then we met with state leadership to discuss some of those implications and next steps. We presented the data at the state's has a quarterly large interagency council meeting that we presented the data back at. To get feedback from an even broader audience, and are currently working with the Department of Public Health to distill it into an infographic. And I'm going to show just kind of our, again, based off of some of the data that we put together, the models that we've started to try to generate in partnership with the state. And I'm going to show them, I'm going to summarize the findings, and then I'll show them on the slide after that. So we learned, and again, it was helpful to continuously debrief with our state about this, but we learned that independent contracting structures, federal reporting priorities, and funding drove high operational demands, high costs associated with training, and limited peer-to-peer support, especially for independent contractors. These costs and limited support fuel burnout, and I did not present some of the comments that we heard around burnout, right? And turnover in the system. People feel undervalued, overworked, not paid well enough. And workforce turnover, right, then causes shifting priorities and limited sustainability of training initiatives. So even if an initiative is in place, most people leave the system, and so it can be really hard to sustain some of those initiatives over time. And those costs and shifting priorities, right, can contribute to low provider engagement and the training and uptake of evidence-based practices. There's a really lot of lack of incentivization to attend training because of the costs of attending it, and because of this, again, emphasis on operational priorities. And altogether, right, these processes may reduce access to high quality care for families in Part C systems. And so we're trying to kind of, again, take some of these system level issues and trying to kind of map out how they play out within our Part C system. And so this is, excuse me, this is the diagram that we are still kind of a work in progress, but what we're working on with our state to really figure out, you know, what are the main kind of challenges that are coming up in our system and how are they impacting. Really, we're really thinking about adoption here. So we're thinking about adoption via training attendance. So in order to use anything, you have to be trained in it first. And so this model, again, I think shows, right, the impact of some of these system structures, right, funding and contracting in the federal reporting areas, how they impact operational demands and some of the disincentivization and costs associated with training participation, and how those things ultimately fuel kind of turnover and some of our training issues. So I think the question then becomes, well, what does all of this mean, right? I think it can be tricky to figure out exactly where to start. I think the good news is that the findings that we, learned were fairly consistent with other, workforce development models, which really talk through the role of operational demands and costs and support on things like turnover. But we began to think about, well, what the heck do you do about this independent contracting issue? I mean, this feels like a main driver of some of the challenges that we're seeing in the adoption of evidence-based practices. I think the first step, right, is to be thinking about, well, how do we actually change contracts? And there are certainly ways to do that, and our state is open to that. But we also heard loud and clear the need for this peer-to-peer support amongst providers, and so, it feels like from a next step standpoint, there are multiple things. The biggest thing, right, is how can we change contracts so that perhaps, right, in order to see a kiddo who is high likelihood for having autism, right, that, they need to be trained in certain models. And then the question becomes, what do we do about some of this lack of connectivity within the system? So we heard a lot about social networks, the need for peer networks, and opportunities for collaboration really consistently emerge as a way to at least kind of increase providers' feelings of efficacy and in the absence of contracting changes. And so I just wanted to talk a little bit about this. I think, and talk a little bit about social networks and kind of how these might be important in systems where we have very isolated providers. And so we know, for example, that social networks are really essential to kind of increase the adoption and the implementation of evidence-based practices, right? In the absence of like when we think of, Rogers' diffusion of innovations theory, provider social networks are really an essential component for kind of the spread of practices in a system, right? And so again, contracting is important, but outside of contracting, right, we need kind of some sort of structure in place by which folks can get support around evidence-based practice use. There's been lots of work in this area to show that social networks do ultimately influence evidence-based practice implementation, possibly through their role in shaping kind of an individual's attitudes, their norms, and self-efficacy around a given practice. I will say we've been, after doing this work, we did start to collect some social network data in our system, and it's very preliminary work to really try and understand, like, is this actually a thing that's happening, or are providers just talking about needing peer-to-peer support, and so some of our preliminary work has shown that independently contracted providers have very small social networks. This both in terms of, social, like pure social support or emotional support, and also related to the use of certain practices. And that the size of individual social network is, at least in a preliminary way, associated with their sense of cohesion and self-efficacy. And so I think that we're excited about that data. I think it's, again, very preliminary and trying to kind of figure out, is it worth pursuing something like that, and thinking about, again, given their role in facilitating the adoption of practices, perhaps, right, there is a way to actually think about systematically manipulating that. And I want to end there and was making sure kind of we have some time at the end for questions, but I'm super interested to take questions, and I think to hear what folks think about some of these issues, and especially thinking through, methods, right, and how do we distill, some of those causal relationships, and thinking, really too also about independent contracting and, what it might mean to change contracts and what it might mean to kind of build structure and build networks in a system that lacks those things. Thanks so much.
Thank you so much, Catherine. Such a lovely presentation and a lot of work that went into this. It's quite amazing. I'll open the floor to anybody who might have any questions for Dr. Picard, any comments. Well, I have a reaction and I'm happy to share it.
Yeah, I love reaction. Those are good too.
I work in a different context, but some of the issues are very similar. I often hear about workforce shortages, turnover, burnout, productivity demands interfering with one's ability to go to training, interfering with their ability to use an evidence-based practice. There's just a high quantity of work that needs to be done, and there's not a real good incentive for postponing that work for educational opportunities or training or so on. So I'm intrigued by the idea of networks and growing one's network and somehow influencing their social support. But I'm also wondering how folks would have the time for that. Again, if the demands are so high they can't attend training, how might they put time aside for, a monthly call or what it might be? So not necessarily a question, just a reaction. I don't know if you have any thoughts or if people have told you, anything about that explicitly, if you've heard anything.
Yeah, I think the question is, what is a network, right? Does a network mean you have to attend group consultation an hour a month, right? Or is a network, right, just a platform by which you connect with other providers that doesn't have necessarily a time demand on it? Because I agree, right? It's like there's some of these bigger picture system issues, right, that are going to come up. If you don't kind of tackle some of those things first, it feels like, you're fighting an upstream battle to try and implement that. So I think the question becomes, again, what is a network? And I think my understanding of some of the work that's been done in this area is a network can be something formal, like a learning collaborative or kind of an ongoing consultative group that has like an active facilitation component to it, right? Or it can literally be, right, an environment, right, where folks are, able to connect with one another, right? It's like a Facebook group is kind of like a network, right? I mean, that's probably not the best network, and it may not, impact change. There might need to be some other active components to actually facilitate connection in it. But I think you're right. You kind of got to really think through like what actually do we care about in a network, and what's the purpose and what are we looking for? Yeah.
Yeah, thank you so much.
Yeah. Yeah, I think that yeah, it's been a really interesting project, and I think we're excited about potentially working with the state to make some of those changes to contracts, but it's like, how do you kind of respond to this like clear provider driven need, right? To your point, in a way that doesn't just bump up against the challenges of the system.
Well, you bring up the state's willingness to change contracts, and that was actually quite surprising to hear. It's not often the case you hear that a state is really willing and eager to change contracts. Again, not a question, another reaction. Um, I'm I wonder if you can talk a bit more about their willingness to change contracts, the kinds of changes they're willing to
Yeah,
make.
yeah, yeah. I think it's so good. So, we are fortunate to have a really good relationship with our state and our partners there. And because of that good relationship, and we've been able to have some of the hard conversations around, what is it really going to take to actually change practice, and they were I mean, the nice thing, right, when you are doing work like this truly with your partners, right, is they also see the data, right? Like this, and so I think they are aware, right, that it's going to be hard to affect change in the absence of some of those things. And we presented data on just like rates of uptake and training and various training initiatives. So they're well aware that it's low. And it's like, if they invest money every year into training. And so we've talked about, well, how can that money be used more efficiently, right? Instead of paying a handful of people on our team, right, to train, can we actually reinvest that? I don't know, we need more money than, than that, but like, can we use that to actually think about some of these bigger picture changes? And we were talking earlier about this, like changing contracts is actually not that costly to do. And the nice thing is there are examples of other states and other systems that have done this, right? That like, I think about other states, right, where if you're going to, again, pick up a kiddo who has screened, high likelihood on a screener, right, you have to have been trained. That's a pretty low stakes change. And so I think part of that, again, that willingness has come from like having a good relationship and really kind of being in this project together. Now, whether or not like that, I mean, I think the other thing that I've learned is that change takes so long. So, I mean, like, it's definitely not going to happen this year and maybe next year, but probably not either, So I think we've been thinking a lot about, okay, well, what can we do in the meantime to really set the stage for that and think about how to do it effectively? And if we can't do that, what are our options? Because that's hard too, if we can't do it.
Yeah, Catherine, I mean, I think that issue, this is Greg Ahrens, the issue of the timeline for change, like policy and practice change, I mean, for us as researchers, I think it's important to understand that it's their timeline, not our timeline. And it's, it doesn't necessarily work to try to impose like a 3-year grant or even a 5-year that change. I wonder what your experience is with that.
Mm-hmm. Yeah, very limited. I think, from a grant standpoint, it feels always easier to have like a much more concrete, like non-policy level thing to do because it feels like you have a little bit more control over those things. But I think in this case, kind of like we've talked about, and everyone I think is probably thinking the same things, which is like, how can you really do anything that's truly going to have kind of an impact without some of those things coming into play first? I mean, you may be able to lay the groundwork, right, in a preliminary way, but not much more.
Yeah, I mean, for me, it's thinking about sustainment as the focus rather than implementation per se, right? Great to learn how to implement stuff, but if we can't keep it going.
No.
Yeah.
Yeah. I think again, like being able to see some of that turnover data too, and again, to be able to show the state, right? This is really the percent of providers who actually do these things, and of those providers who do them, how many of them then turn over, right? And so like you get a really very, very jarring and kind of objective picture of actually what kind of impact you're having on a long-term basis. Yeah, I agree.
I'm wondering if you could talk just a little bit about like the method of this like causal coding, because I think it's so interesting, right? Like people tell us all the time why something's happening, right? Like, I don't do this because I can't afford to, right? Like, I'm, all of these things that they're just telling us that we often are like, oh, well, we have to go get our quantitative data longitudinal over time. So I'm curious, like, I haven't seen that used before, but it just makes a lot of sense. And so I'm curious, like, how you've used that, what you learned from it, any recommendations for other projects who might consider it?
So I think I really enjoyed it was really intensive, like kind of time intensive to do, just because you don't just code the data, you then have to pull all these things out. And but I mean, I think it was really helpful. I mean, it's tricky because in hindsight, I think there are probably different ways we could have asked questions that might have given us even richer data than we got from it. But I thought it was a really nice way to at least have that mindset in this project, which is like, can we try and at least get some of these relationships kind of mapped out? And part of the reason, again, we did it is because because we were particularly cognizant of independent contracting in the system, and we're worried, right, that some of the measures that exist so like today are really focused on organizations, and that we might not we just weren't really sure. And so this felt like a kind of a nice way to do it. Again, it's provider report, but I think what we learned was valuable.
Thank you. It is really interesting. I think
Yeah.
you're excited.
Yeah, I have not used it since. So, but I think it was a good exercise, and I would love to do it again, actually, in a more systematic and thoughtful, even more thoughtful way. Yeah.
Well, I'll thank you again,
Yeah.
Catherine, for this wonderful presentation today. We so appreciate you taking the time to meet with us also, and join some of our CASRIC activities today, but also for this lovely webinar. Really tremendous work that you're doing, and a lot of it. You must be very busy. I see if folks have questions, they can email you later,
Totally.
it looks like.
Yeah.
And
That's
we
great.
will certainly be in touch moving forward.
That's great. Thank you so much for having me. This has been awesome. Like really, really,
Yeah.
really fun.
Yeah, thank you again.